Well, good afternoon, everyone. My name is Sarah Merrifield, and I am the Senior Program Officer at the RIZE Massachusetts Foundation. RIZE is very proud to be part of this groundbreaking partnership with the National Harm Reduction Coalition and the National Association of Social Workers Massachusetts chapter to expand knowledge and create space for dialogue about harm reduction and social work to advance practice and deepen relationships with clients. We are so pleased to welcome you to this final session in a three-part series focused on cultural humility in the practice of harm reduction. For those of us who are joining us for the first time today, welcome. This session can be experienced in any order, and all three of the sessions will be recorded and made available to you online through the National Association of Social Work's Online Institute. And for those of you who are new to RIZE, a bit of background. We were launched back in 2017 as the only public-private partnership solely dedicated to funding and creating solutions to end the overdose crisis. Our goal is to ensure that people suffering from substance use disorder have access to care and experience better quality of life and overall health. Guided by those with lived experience and unafraid of new ideas, RIZE is building networks, creating programming, and supporting community partners who are using novel approaches to preventing overdose. One of our strategies to end the overdose crisis is to bring people together, to share learnings, support exploration, and enable change. That is once again our goal for today. As the opioid crisis continues to take a devastating toll, strategic workforce investments like this one will ensure that professionals like social workers who provide critical, direct care are given all the tools they need to support clients experiencing opioid use disorder. Harm reduction offers a set of practical strategies and ideas that are aimed at meeting people where they are and reducing negative consequences associated with drug use. And social workers are uniquely positioned to integrate those practices to improve client well-being. Before we get started, here's some brief housekeeping. The webinar will run from noon to 1:30. All participants will be muted throughout the webinar. Please feel free to add your questions and comments in the chat, and we'll reserve the last 10 or 15 minutes or so for question and answer session. There will also be a code given to you at the end of the webinar. All participants will need to enter this code in a course evaluation form to get credit. Thank you so much for taking time to share your feedback. You can find the link to the form from the email you received. The slides from today will also be shared with you after you complete the evaluation form. Again, this webinar will be recorded and posted to the National Association of Social Work's Online Continuing Education Institute. And for this series, we will once again be led by our partners, the National Harm Reduction Coalition's Tanagra Mahalejo with Joe Fiera of Outlook Associates of New England. I will now turn it over to you, Joe and Tanagra, and thank you all once again for joining us.
Thank you, Sarah.
Thank you, Sarah.
Thank you. I'm so excited. Bienvenidos. Welcome everybody for being here. So I'm going to briefly share my screen as we start this third and final session. And I have to say that it's been incredibly amazing for me to have had the opportunity to be in community with folks for this past 3 weeks. You know, we worked really, really hard, Joe and I, alongside Barbara and Sarah and other folks to create this program. And, you know, this final session, we have the privilege and the opportunity of being in conversation with someone, with folks, you know, with someone that I really appreciate and care about, who's a friend, but also a mentor, and someone that I profoundly respect as a harm reductionist, as someone who not only talks the talk, but walks the walk, and it's incredibly generous and with their expertise and their knowledge. And so I'm excited for them to be joining us today. And before we go into introductions with our speakers, we will be, you know, thinking about the practice of harm reduction and cultural humility, you know, in our work. How do we bring those two together when we're working with participants, with clients, and with patients, and what that it means for clients that actually are lucky enough, or when we're lucky enough to have a practitioner that is embodying those principles in their practice. And so we know that some folks maybe are new to this space today. You have not been able to join us in the previous two sessions. So I wanted to take some brief time to give some context as to how we got here today. So we have been working, Joe and I, RIZE Massachusetts and the Massachusetts chapter of the National Association of Social Workers have been working together for the past 3 years. And we have been able to put out 2 programs. One of those programs happened last year where we did 2 sessions that spoke about harm reduction and the intersection of harm reduction and stigma when we're working with clients who use drugs or participants who use drugs. And then, I think it went well. And we decided to work together again. And we were thinking, so what would be the next step? And we received a lot of feedback from folks in your evaluations, those folks that attended those sessions. And one thing that came up was 2 things, was how do I do this work when I am someone who's not coming from the same cultural background? I am not someone who has lived experience or living experience with substance use. I don't have a lot of information about it. I want to be able to do it well. I don't want to hurt people. And also, how do I do this work, with bringing harm reduction into my practice? And so out of that, came this idea of bringing a series of trainings that spoke to that intersection of cultural humility and harm reduction, and also the space to make mistakes, which is also addressing how do we as social workers are swimming within white supremacy culture, and that is impacting us and affecting us as not only social workers and human beings and providers, but also in the way that we can engage with people. And so, that we had 2 sessions. The first one was an introduction to the principles of cultural humility and harm reduction in our practice. And then we had a session, I think last week, where we spoke about how can we give ourselves room to make mistakes, and why is that important, and why is that part of both, the principles of cultural humility and harm reduction. And then today we wanted to hear from folks, from people who have had lived or living experience, and also have sought out support from social workers or clinicians, and what it has meant for them to receive that from a harm reduction lens, from a culturally humble lens, and what has been challenging, what that has not been the case. And so when we think of harm reduction, we know harm reduction works. And this is why we talk about it, and we tell you that it does work. It works because it provides safe space for people to be themselves, to be open about their lived experience or living experience with substance use or other behaviors that are part of who they are, but not who they are. And that, if we don't have that room for that conversation, that we're missing out on who this person is. Those may not be the things that people lead with when they come to you to therapy, and that is okay. And if we allow a safe space for people, if it's relevant for those things to come up, they will come up if we provide that safe space. We value people's expertise. Harm reduction is telling us that the participant, the client, the patient is the expert, and they're the ones that are sitting there, and we need to follow their lead. We need to be open to learning from folks, cultural humility. We need to be open to saying, I don't know, and I'm willing to learn more. Or I don't know, would you be willing to be my partner, and can we work together so that I can learn from you and I can share some of my expertise with you too. Harm reduction is rooted in evidence-based practices. It is science-based, it works. I think that this is important, but I don't think we should be practicing harm reduction only and solely because it's evidence-based. We should be practicing harm reduction because we should care for people. We should care for people. We should love people. We should work with people from a place of love, deep compassion and empathy and respect, because people are human and deserve to have human rights. And because we don't have, why oppress people when we have other avenues and ways to connect with them and center them. And finally, harm reduction works because it allows us to keep folks engaged, even if they are not ready or they don't want to address change around their substance use. That is okay, because we can create a space where we can actually address their needs, and they may have many other needs that are not being met. And as practitioners, having that rapport and that connection and that engagement is really important. And then finally,
Naga,
yes.
Oh, sorry, can I add?
Ahead.
Yeah. So I also want to say that I think it's really important for us. So wherever whatever setting that you might be working in, whether it's substance use focused or not, you are going to interact with people who use.
Mhm.
And I really think and that was one of the trainings that we had last year, was that you do not have to be an addictions expert to work with somebody who is struggling with substance use issues. And I just think, given the extent of the problem, that it's really important for people to be open. And I really think harm reduction is very user-friendly. It's about engaging in a conversation with individuals, and it's just also good therapy. It's good therapy practice. So I would just have people keep that in mind as they kind of move forward from these trainings, that it's really important that you be open to working with people with substance use issues, even though you feel like you don't have an expertise.
Thank you, Joe. And it's okay to make mistakes, right?
Yes.
And we can learn from that. And it's okay to say, I don't know enough about this, and I can go out and learn. And there's the webinars that we created for these sessions, the webinars that we worked on last year. There's tons of information and resources. I'm sharing a resource with you right now. This is an opinion, an op-ed that was published, I think it was last year, in the New York Times by Maja Slavitz, who is a columnist for the New York Times and a harm reductionist. And I just want to remind us and center us that harm reduction, this practice that has been around for 40 years, is a gift to us by people who use drugs. It's a gift to us that we are using to address, have used to address the COVID pandemic, that we have used to address the HIV pandemic, that we're using it to address many other things that are happening in the world. And it's a gift to us from people who use drugs. And as a gift, is also asking us to learn more about it. And so if you go to that link, it'll give you an introduction if you're not familiar to harm reduction. If you want to learn more about harm reduction, I think it's a really good piece that, you know, I hopefully will be an amuse-bouche. It will give you the opportunity to seek more information about harm reduction and learn more about it, and also learn from people who use drugs, who can be our better teachers too, the best teachers, I think, when we think about harm reduction. And so before we go ahead and present our speakers, Joe and I have a call to action to you all. And we do this from a place of love and respect for all of you that are doing this work, and that are here because you're interested in learning and expanding your expertise, and are curious about this. And this call to action is the following. As we all, I'm going to include myself here, as we all listen to the folks that are sharing very generously their wisdom and expertise today with us, I want us to consider how we can integrate their individual perspectives and expertise into our work. You know, I want us to be open to learning from folks and open to hearing from folks, and being challenged for those folks that are here today. So I am going to stop sharing my screen because this is not necessary. And I will pass it off to Jason to introduce himself, and then to Tavis. Thank you, Tavis. Welcome. It's nice to see you. So I will let Jason and Tavis introduce themselves, and then we'll just be chatting with them. I wish we had some coffee or tea, and we had some nosh, some good rugala, and maybe some good donuts. I like a sweet with my coffee, maybe some cookies, whatever your favorite cookie is. And we were sitting around in a room with sofas and chairs to have this conversation. So we'll imagine that's happening as we speak. So I'm going to pass it to Jason and then Tavis to introduce themselves, and then Joe and I will go ahead and get started with some questions for both of them.
Hey, good morning, everyone. My name is Jason Norelli, and I just want to say that I am currently broadcasting from a very busy treatment milieu. It's a residential treatment program and a withdrawal management program in San Francisco, California. And yeah, so I've had a long career in both abstinence-based treatment and harm reduction. And I think that's everything. Do you need any more information?
No.
I think that's it.
Thank you,
Hello,
Jason.
everyone.
No.
Thank you.
Tavis, do you want to just briefly introduce yourself?
Sure. My name is Tavis Carter. I am in Boston, Mass area. And I have worked in every modality in substance addiction. That's the politically correct statement these days. Known to man, I enjoy my work. I am also a person in long-term recovery, so I've been on both sides of this coin, if you will. So just a wealth of personal and professional experience. Thank you. It's nice to meet everyone today.
Thank you. Thank you. So, Tanagar, do you want me to start with the first question?
Yeah,
So-
and also before you start, Joe, I wanted to say to folks is as you're listening to both Tavis and Jason, if you have questions that you would like to ask them, please type them in the chat box, because we want to make sure that we leave room 15 minutes at the end to ask those questions. And I know that Jason and I'm sure Tavis probably have to jump off right up at our time to go back to work. And so I want to make sure that we can get as much of their wisdom as knowledge as we can in the time that we have. So thank you, Joe.
Great, thank you, Tanagra. So the first question, actually, it implies an assumption, and if it didn't occur, that's actually wonderful. But how did you perhaps first encounter prejudice or discrimination when you decided to kind of engage in services for your substance use issues, whether you encountered prejudice or discrimination, and how did that kind of land on you?
Well, I think for me, what fits that question is I had to go get a physical. And I've had many physicals before, and I know what a good one looks like, and I know what a half-assed one looks like. And I'm pretty frank. I'm not disrespectful, but I'm pretty frank. And the woman doctor, female doctor, who was my primary care physician, she felt my throat. She banged me on the knee. She listened to my lungs and told me to get dressed. And I just didn't feel like I had gotten a physical. I was vaguely aware of like blood and urine and the importance of, high risk, and I definitely felt that was racially motivated. So that was my experience with that, but I did go on and file a complaint with the Board of Registration, and she had to answer up for her lack of professionalism or thoroughness, if you will. And I got a complete physical by somebody else.
What comes to mind immediately when you ask that question for me is my involvement. I also am a person in long-term recovery, and when I was in the throes of active drug use, I banged around in the criminal justice system and could feel the different kind of treatment I was getting because of what was happening for me. And then I think that's the main place that I've felt that kind of treatment that was treated like the other, if you will, and that had an effect on me, and I ended up getting mandated to a treatment program, which ended successfully. And actually, Maya Salovich did a piece featuring me about mandated treatment, and because I'm could be construed as a success story for mandated treatment, I actually do not advocate for that. And I have actually been a counselor for many clients that have criminal justice involvement, and I don't think mandated treatment is the way to go. Yeah, so that's my thought on that.
Can I just a follow-up question, Tavis? did this PCP, was this while you were also using? Did she know about that?
We
Yeah,
knew about it. I had been abstinent for quite some time.
I see. Okay.
And now that I'm not using and getting high, I kind of got interested into my personal health,
Mhm.
physical
Mhm.
health.
Yeah.
And
That part, yeah.
it would have been nice if she took it as serious as I did, but
Yes.
I'm pretty frank. Using or not, I could not leave the color of my skin outside that room.
Mhm.
Mhm.
My friend here, Jason, mentioned the criminal justice system. I don't know if that would apply here or further into some of the other questions, but I too had a similar experience with the criminal justice system, and like everybody using, whether you're black or white, has got this story of how it's not my fault. I don't know if you care for me to respond to that now or save it for a more specific criminal justice related question. I'm trying to pull up my questions so I can look at them, but of course I left that printout home, but I have it in my email.
Yeah. Thank you, Davis and question. I have, as you're speaking about your experiences with, prejudice and discrimination, I think that, as if we've experienced that, we know that that weighs on us and is something that we carry, right? That is connected to stigma and that impacts us in that moment and also long-term, particularly our access to services. Like for example, I had an issue with my eye when I was in California, and I had to make an appointment with urgent care. And I had no idea that you only could check yourself, they could only check one thing in urgent care. I had like another concern. It was like, no, you're here for your eye or you're here for this other thing. I was like, well, I'm here for my eye. So this doctor walks in and I'm, you can see my tattoos. I'm sitting there, right? And he comes over and he has no bedside manner, right? He's checking my eye and he's like, I hear him cutting. They're like, and he goes like, hey, did you know that your pupils are really constricted? And he said it in a tone where I knew what he meant. I knew what he meant. He was making an assumption about me in that moment, and I was pissed. So I said to him, well, I didn't know that because I don't have a mirror in front of me to look at my eyes to know that my pupils are constricted. But what do you mean by that? What does that have to do with my eye issue? Right? And he couldn't tell me because what he was saying was, I think you're high. And I think you're using drugs, and I think you're here because of that, right? Which I'm not ashamed or embarrassed about, but also the way that he treated me, the way that he didn't really answer any questions about my eye, which is what I was there and concerned about, had an impact because I wouldn't go back there to get treatment. And I left with my eye feeling really bad and having complications later, right? So I wonder if you can share with us a little bit about, once we experience that experience of discrimination and shaming us, right? When we're accessing or trying to access services, what are other ways that sort of like spreads out or gets its claws or tentacles in other areas of our life? If you could just give us some examples of the impact of that in other areas, including maybe potentially addressing issues of seeking treatment or seeking other care.
Well, it made me hypervigilant around being treated as a second-class citizen or a quote-unquote druggie who is, the epitome of drug seeking. And I also don't put addiction, I have not allowed addiction, to be placed in my medical chart. Because we all attend conferences and we talk about the cruelty of stigmatizing patients. Don't blame the patient for their illness. Sounds good on paper. But in practice, it happens all the time. So I say, I used to have an alcohol problem because it's so much more palatable in professional circles. And they're like, oh, we're we're just glad, you know, that you got some help and things kind of got better for you. That's great. That's great. If I tell them, look, I was banging a gram of heroin a day, and they're like, no narcotics for this guy. And what happens
Right.
is, along with the myth that Blacks are somehow more tolerant of pain, you come home from surgery, here's your 2 pain pills. After that, we suggest you visit the local CVS and ask for extra strength something, because we're not giving you anything.
Mm-mm.
And it's sad
Mhm.
while you take your hypocritical oath to do no harm.
Mhm. Yeah. Yeah. Thank you, Davis. It's sad and it's enraging. I have
Yeah.
to say,
Yes.
you know.
It, Jason, well, I'll let, did you want to add to what Tava said?
Yeah, I mean, I agree with all that. And I really liked what Tava said about the hypervigilance that comes with repeated treatment on this level, stigmatized treatment. And I think that's something that gets replicated so much that as clinicians, when we're engaging with someone who uses drugs, we have to be conscious of that, right? Because you know, I don't know, there's a terminology that they use in jails that like you wear the jacket of your crime. It's like a garment that you wear, you know, and it's like you know, once you've been treated like that in enough settings, you're preloaded with a response already. So I think clinicians need to keep that in mind when they engage with drug users, because you know, as a former drug user myself, I can feel that. And even after many, many years of a couple decades of recovery, I still see that hypervigilance pop up when I'm engaging with practice. Like, you know, like I said, like I minimize with medical professionals the extent in which, you know, I don't tell them that I'm a former injection drug user, because, you know, that comes with a certain stigma, like Tavis was saying. I agree 100%.
It just kind of both of your comments reminds me. So I've not had that personal experience of being excluded, but time and time again, I've had clients, and I'm working with a woman right now who has been on Suboxone. She has this doctor who prescribes Suboxone, but last year, I think her PCP has quieted down, but wanted her to get off the Suboxone for no other reason than she should, you know, in her opinion, she shouldn't be on it. And it was just, and you know, fortunately, my client had enough of kind of a internal strength to say, you know, I have a doctor for this, and I'm going to follow that doctor's sort of recommendations. And but it just, she gave no clinical reason from my perspective on why this person should get off of Suboxone. And it's just time and time again that people are faced with this kind of sort of stigma. So
Yeah, and to respond and push back to it takes a certain amount of strength based on, you know, your own opinion of yourself, your self-esteem, right? And if that's been eroded, you don't really have the strength to advocate for yourself.
Yeah, I would also say, and after that, thank you for bringing it up, Jason. I think that we cannot forget the intersections of people's identities, right? As female identified folks, you know, in a really patriarchal, misogynist culture, it's really hard sometimes for us to push back, because we've been taught we have to be small and quiet and take care of other people's feelings. We cannot, you know, bring stuff up that is controversial or that can cause some kind of como se dice en inglés? Oh my God, I'm thinking about English. You know, you don't want to call attention to yourself. You don't want to make people uncomfortable. I know for Black and brown men, you know, there's notion that, like, you know, there's you know, if you say something and you're deemed angry or arrogant or violent, right? And so I think thinking about also that those intersections too of you know, and how they play into what we're talking about, sometimes it makes it even more challenging for someone to push back or call out, something that a provider is doing that is hurtful and harmful in the end, right?
So I'm curious, Tavis, and also Jason, when you so Tavis, clearly in your encounter with the PCP person, the kind of the being treated differently and the prejudice and the discrimination. I'm curious. I think I may know the answer to this, but when you've encountered providers, how well do you think they are at addressing, if you were to bring it up and saying, hey, I think you're treating me differently because of X? How well do you think they would respond to that? And have you ever had that conversation with a care provider?
I have not, because I think it would be an exercise in futility.
Hmm.
I'm the expert. I'm also white.
Mm-hmm.
And you don't know my illustrious history and formal education. But I know yours because I've looked at your record. And I'll ask the questions here and I'll decide what is standard and substandard care. And so I am very cautious and even attempting to have a civil conversation that involves race, prejudice, discrimination, and unethical delivery of services. First of all, they want to know, where'd I learn how to talk like that?
Mm-hmm.
Because you're a junkie. And I don't have time to bring you up to speed. That's what company policy and our other state agencies are for, to pull you on the carpet with your white counterparts that will have you respond. And that's why I was very pleased with the results I got. And I only really felt good is because she might think twice the next time she enters a room to give a person of color a physical and is fraught with white fragility, or I just want to hurry up and get this over with. It's not a good feeling when you get the sense that a medical professional does not want skin-to-skin contact with you. Now, I could be wrong. I leave that window open. But the odds are that I wasn't wrong.
Mm-hmm.
Jason, it seemed like you had a response to what Tavis was saying initially.
Yeah, it just it hurts, to like feel that. And what I was thinking of actually was my experience of working with people of color, Black folks, and and how I'm perceived in this context, right? Because I'm of Irish English descent. I like to keep my hair cut short. I look like a fucking cop, for the lack of a better word. So I have to do extra work to kind of like reach across the therapeutic alliance with people, because the mistreatment of drug users, if you add on the layer of racial inequities and mistreatment of that, it's a pile of complications that you have to unravel, and if you want to have a therapeutic alliance with someone who's a culturally appropriate, friendly, compassionate therapeutic alliance is a little further away than than first blush, because of all the things that we're talking about.
And I'm thinking, you know, like as I hear you speak, I don't know, Joe, but this is something you and I have been in conversation with. And I think there's a question in the chat box that is asking, you know, like, do people in medical schools or in other settings get to hear from people with lived and living experience about some of the things that we're discussing? And I don't think that's the norm. I don't think that happens very frequently. I think that we don't talk about harm reduction. We don't talk about cultural humility. We don't talk about any of these things, right? I think that's one of the reasons why the systemic inequalities continue perpetuating themselves, right? Because we are working with people that are embedded in systems that are swimming in white supremacy culture, that are swimming in inequity, that are swimming in judgment towards people that are different, or that are considered to be engaging in behaviors that are wrong or bad, right? And I think about the impact that that has on us, that it has on our communities, on our families, on our friends. And I think about, you know, the idea of being humble to learn from others and to make mistakes, right? And I think as part of being a social worker, you know, you're taught, you know, traditionally you have to teach people, you have to tell people what to do, right? You know it all, you're the expert and they're there to learn from you. And I think shifting that mindset it's challenging and also so rewarding where you're able to do it, and it's a lifelong practice. Right. So I'm thinking, you know, if you're thinking about folks that are engaged in social work that you're around, are you know, people in communities, in the spaces that you're in, how can you tell when a provider is actually coming to us from a culturally humble and harm reduction background? What are the things that you have noticed that those providers embody that let you know that they are also embodying those practices?
I'll let Jason respond first this time.
Okay, thank you, Travis. I have
It's
this.
Davis. It's a long A, like Avis
Sorry,
Rent-A-Car. Davis.
sorry, man. Davis.
Joseph got it.
Yes, yes.
Yeah, I mean, I have this personal story kind of locked and loaded that I'm going to go ahead and reveal right now, which is that I was in abstinence-based recovery for 21 years. And in the last year or so, I've allowed myself to use certain substances, you know, mainly alcohol and marijuana and stuff. But I had been lucky enough to have a harm reduction therapist. And the advantage of that is that that I get to unpack these things in a non-judgmental way, and it's not you know, it doesn't have all the usual hangups with you know, folks who are judgmental about drug users, and so it's been super beneficial to me personally to have a harm reduction therapist engage with me around the stuff that's going on for me. And I want to say too that I have a lot of the sort of implanted rhetoric from the 12-step world circling in my head as I, you know, am engaging in not being abstinent anymore, because I was abstinent for so long, right? And all that programming kind of worked its way into my life. And, you know, it could be argued that it helped me survive through, you know, years and years of, you know, abstinence-based recovery. But, you know, when I made that decision in my life to open myself up to be able to use certain substances, you know, I didn't slide off into oblivion or whatever, like the kind of rhetoric that gets pounded in you in 12 steps program, you know, one is too many and 1,000 is never enough, all that kind of stuff gets reprogrammed, and you replicate it and you identify as an addict and all the things, right? So it's been really, really beneficial and helpful to have a harm reduction specific therapist during this time for me.
So Jason, I have just a quick follow-up question.
Sure.
I know that you work in the field. How did you find out that, was it somebody that you already knew? Was it a person that was somebody gave you this person's name? How did you sort of, yeah.
I lucked out. So this is like someone who was providing clinical supervision to my partner who was running during COVID, a safe sleep site, they call it in San Francisco, which basically is like a sanctioned tent encampment or whatever. So, and you know, I would be making dinner while they were, doing their thing, clinical supervision wise, and we developed a friendly rapport, and then I eventually was able to take him. He was able to take me on as one of his clients, and I'm super grateful for that.
So, as I like to say in court, Your Honor, could you repeat the question?
Yeah.
I'm also a part-time comic. I actually am a comic. It's just a little therapy from my way too serious life in recovery. But what was the question again there, Joseph?
Actually, Tanagra can ask.
think
Yeah.
what we wanted, I was just thinking about how do we know, or how have you known when you're approaching a provider, whether it's a medical doctor, a social worker, a case manager, that they are embodying the principles of cultural humility and harm reduction? What are some of the things that you have noticed that can help you feel or know that this is a person that is open and welcoming you into the space differently than your previous experiences?
Well, a couple of things come to mind. One, I'm a spiritual guy. I'm also all about energy. And thirdly, I'll use the term loosely, but addicts are some of the most perceptive people walking the face of the planet, because
Yeah.
we've had to become those people
Right.
in that world on the street. And I got clean, but I didn't lose those things. They actually got enhanced because the drugs are out of my system.
Mhm.
I can somewhat sense if you're going through the motions, if you're checking the box, if you come in with an air or attitude of, I've got my playbook and my play for our meeting today, and we're just going to do that.
Yeah.
Also, as a clinician, grad degree holder, and all of that stuff, there's other things I've picked up along the way. One of them being upwards of 80% or more of our communication is nonverbal. So you put that with all of those, I call them my spidey senses, right?
Mhm.
And it isn't
Yeah.
long before I get a sense this person is genuine and invested in me as their patient or client,
Yeah.
versus they're going through the motions and doing their part in diversity, equity, and inclusion and cultural competency.
Mhm.
You cannot fake this stuff. You're either really involved, invested, trying to learn, because everyone doesn't get there overnight, or you're going through the motions, maintaining the status quo.
Mhm. Yeah.
There it is.
Yeah.
Thank you, Tavis. There's
Yeah, really.
thank you for sharing that. Jason, do you want to add anything? There's a
No,
good question in the chat that I want to ask you too.
Yeah, no, it's a really, really great point, and definitely like the thing that I find myself repeating to people that I supervise is like the it's energetic in nature, and you can feel it before any words get said, right? It's like it's how you're arriving in the session, right? And people and drug users who've done the street thing and whatever have to develop that survival strategy in order to make it in the world. Like you can size someone up half a block away, what is this person coming at me with, and it's a survival thing.
Yeah.
Can I just add too, I know Tavis and Jason, you last week when I presented a case where I made a mistake in terms of a cultural sort of disconnect, and the person, not to go into too, but the person made a comment, and to Tavis's and Jason, sort of, I didn't say anything, but it was all in my face.
Yeah.
Kind of the look of like, what did you just say? And again,
Right.
I didn't say anything. It was just a sort of a facial sort of communication with the person. So, yeah.
Right.
There's a really great question in the chat that Sarah asked, and I want to ask it of you. It's which made me think about, what are some concrete examples, right, of harm reduction in action when we're in therapy, right? And I can think of an experience that I had, which I went to a therapist once, and I walked in and they were nice, and again, the energy, I could see, sometimes you walk in and you're like, let me just give this person a chance. I just didn't feel the energy was quite there. I also believe in that, like, I feel like energy centers are here in our bellies, right? And so they said, why are you here? So I told them, and I said, I'm here because, I've been having this situation, and I have these nightmares, and I've been using alcohol to help me sleep. And I, don't want to, I don't feel like that's something that is helping me, because it's brought on these other things that are more problematic for me. And I think that I kind of know what I need to do, right? So I explained that to her, and she looked at me, oh, that's great. That's wonderful. But that's not why you're here. That's not your problem. Right. And so she immediately went off to tell me all the things that were wrong with me. Right. And so I listened, I was there, I got up and I left, and I didn't go back to therapy for 5 years. And then finally I tried therapy again, and I walked in and I sat down, and this person, felt really comfortable with them. And they asked me, like, why are you here? And so I kind of was hesitant to explain why, and I sort of said the same thing that I said. And one of the things that she said to me was like, I thank you for sharing that with me. It seems that what are some of the issues that are bringing you here, and what I want to hear from you, if that it's okay. It's like, what do you need from me, and how can I be helpful, and how can we both work together? And that made such a huge difference to me, right? Because that told me that this person was willing to hear from me, to center my experience, right? And so that to me is an example of like harm reduction in therapy and practice from my experience. So I would love to hear from both of you, if you can share, when you're in therapy or in counseling, what does that look like? What in action?
Well, my experience is very minimal, because I've always subscribed to a total abstinence philosophy. But in my professional career, I've had to practice open-mindedness, if you will, Jason, around this person may need to stop by my desk while I'm working in a medication-assisted treatment program on their way to total abstinence, if and only if that is their goal for recovery, not mine. And out of 200 clients I saw 5 of them actually titrate off the clinic, so to speak, and not show up in the intake room 2 months later. And I'll take it. But once again, it had to be their goal, not mine.
Right.
My personal philosophy of total abstinence is just that, personal.
Yeah.
I can't touch anything and stay right there. I've done the research.
Yeah. Yeah.
So I've never had anyone talk to me about quote unquote harm reduction, although I've been in therapy, unless it was harm reduction as it relates to other self-destructive maladaptive behaviors, not necessarily substances.
Yeah. But centering, like,
Go ahead.
but no, I wanted to say that it seems to me that in your practice, the way that you embody harm reduction is by really centering the expertise of the person and allowing them to determine what that looks like for them, what this journey will look like for them. And I appreciate so much what you share about my personal experience being personal, right? This worked for me, and I know because you did the research, right? And that doesn't mean that it would work for somebody else, and that's okay. And you're there to support them. So I really love how you framed that, Tavis. Absolutely. Thank you.
Well, the treatment must be individualized. Jason's name is Jason. Joseph's name is Joseph. The days of the cookie cutter approach are long gone, and everyone's moved on. Have you?
Mhm.
Yeah.
If I could just add that
Yeah.
my partner likes to frame harm reduction as lowercase and uppercase harm reduction. Lowercase harm reduction is like the stuff of harm reduction, safe injection supplies and pipes and all the stuff that helps people use safely. And then uppercase harm reduction is like the philosophical side, and what that embodies is exactly what Tavis just said, which is honoring the autonomy of the individual that you're communicating with and allowing them to make choices. And if I could just tell a really short, quick story, is that like when I started my career, I worked with criminal justice folks, and my job was, it's a horrible name of a treatment program, it's called the Offender Treatment Program. But anyway, they taught me to do assessments and then make findings from what the assessments were, and then just refer people to treatment and all that kind of stuff, right? And I always got critiqued by my supervisor for being too client-centered, if there is such a thing. But when I run into clients that I worked with years ago, they say, the ones I worked with back then before I understood harm reduction, they're like, you helped me do that, you helped me, right? And as I transitioned into working in harm reduction, the clients I run into now say, I did that, right? Because I hand all of the power and all of the autonomy back to them and re-emphasize it, right? Like, here's a bouquet of options, which one sounds good to you, right? As opposed to my assessment shows that you need treatment or whatever, to relate back to the cookie cutter thing that Tavis just said, those days are long gone. And I think that the real jewel of harm reduction is handing it back to the person that you're working with as the expert of their own life, and allowing. And here's the thing about when you do that, people own their change. They own their change rather than they told me to do this and I did it, and I walked through this treatment program or whatever it is, because they told me to do it. Whereas if it's an option for them to do a whole spectrum of things and they choose the one like that, then that'll be like, I brought myself to that. Right. And so they end up owning their experience more, which I think helps retain any changes that were achieved during that process.
So, Jason, just to kind of follow up on that, I think, so I started in the field 35 years ago. And it was from an abstinence only sort of approach. And I think, through the years, kind of gradually sort of coming to embracing harm reduction. And Tanagar, to your point about Maya's sort of article about it really has been a gift, because I feel like I'm more open. So rather than imposing or feeling like, okay, this person needs to be abstinent because their lives are so chaotic and crazy, it allows me to back off and sort of engage in a dialogue and conversation and not be so sort of caught up in my agenda rather than, and I know it's so sort of obvious in a lot of ways, but I think certainly speaking from my perspective, it can get very easy to fall into, okay, this person, they're doing XYZ, they're dying or whatever, they need to go this way. So it's so easy to fall into that, and versus taking a step back from it. I'm curious, another question, I think Tavis, you sort of answered this, but I'm going to ask it again. So if you had to give advice to a person who was dealing with a care provider who was maybe prejudiced or discriminatory in some way, how would you tell them to approach it? Or would you say, just find somebody else?
To answer your question, I wouldn't tell them to find someone else, because that leaves that impaired professional in place. Okay. And doesn't hold them accountable for best practices. Like in my personal situation, it was more about the person of color, specifically males, Black males, that are still home dying from prostate cancer, rather than go and see a provider who's more than likely white with a preventable condition.
Mm.
You know, that's sad in 2023.
Mhm.
And this was a few years ago, but it was just as sad. It's still sad.
Yeah.
So what I would say to the person is, if they're versed enough, attempt to educate them that one, discrimination, prejudice, and anti-Blackness is wrong. Given the particulars, it's also illegal. You know, you may not lose your job, but is this something you'd like on your record? You know, and could you direct me to your HR department where I could possibly pick up a complaint form? And usually people, you know, start backtracking and denying, and they're like, you know, there's obviously a misunderstanding here. Well, now that I have your attention, here's what you did, and here's where it was problematic for me. I'm hoping this is not your standard way of doing business with all your patients, or is it just me as a person of color? Because that's what I'm sensing. That is my experience here. Can't speak for the others, but what you just did was not cool.
And you'd be willing to give them a second chance?
I would be willing to give them a second chance,
Mm.
but they are on notice, if you will.
Right.
And in my previous mentioned experience, at the time of this offense, I was a very active member of the Patient Advocacy Council in that institution. And they were struggling to have particularly men of color, you know, join up, get involved of their free time. You know, there were no stipends. You got a decent sandwich, you know, somewhat dinner, but that was it. But I did it for the people who don't have the wherewithal to be really good advocates for themselves and are subject to taking whatever the healthcare industry has to offer. Whether it's right or wrong isn't important. Hey, we gave you something, you know, you look fine to me. And I'm like, no, there has to be more equity in this service.
Yeah. I mean, it makes me think also, Tavis, as you're speaking, that bringing it back to some of the things that we shared during the cultural humility training, right? I think there's an issue also of representation, right? We cannot not name that we are embedded in systems, medical systems, clinical systems, care systems that are white supremacists, that are really not rooted in having access to representation for people that come from different backgrounds, right? And the harms and challenges that poses for people, right? I think that if we had folks, I feel for me, if we had more folks that were Latino, Latine, right, that spoke Spanish, that were able to, that I could connect to, and that could understand my background, my expertise, my experience, particularly as a Puerto Rican woman, my experience in healthcare would be very, very different. I feel so lucky to have a therapist that works with me, who's a Puerto Rican woman, who I feel I can speak to in Spanish, and I can explain to her things. And sometimes I don't have to explain them because she gets them, because they're there. And it's not like she's gonna look at me like I'm bananas or like, where is this coming from? And I think there's this lack of representation with our systems, right? That has to do with racism and misogyny and trans and homophobia and the harm that causes. And also, why is it that folks that are white are so threatened by having representation, by people like you and me being able to go to a doctor and finding a doctor that looks like us and that is able to connect to us and to our experience, and that understands that Black men don't want to go or feel very hesitant about getting care from a neurologist to deal with prostates, right? And that's bringing up, you know, the rates of cancer in Black men, or that there's a huge, horrible numbers around Black maternal mortality because they're not believed and they're not cared for. right? And when they go to get OBGYN care, right? Like, why having that representation for us as people will take away anything from the access that they have to care as white people? Like, that's a question, you know, around representation that I feel, why would it take anything away from someone who's sober and never used drugs to have doctors, social workers, people that do any kind of care, that have expertise, whether it's lived or living as a person who uses drugs, right? That people who use drugs or have used drugs could connect to and get their care from, right? Like, why would that take, how does that take anything away from those that have not had that experience, you know?
Well, I'll give you the short version.
Tell me.
People, human beings in general, but I'll preface this with white people specifically, tend to fear that which they do not understand. You have not taken the time or care to understand the culture of Black and brown folk. Somehow you've become the common denominator and the standard, if you will. We say African American, we say Asian American, we say whatever else American. Do we say white American? No, because somehow society has propped you up to be, you know, the mark to meet. And, you know, I have to like really self-regulate sometimes because I love this stuff, but everybody doesn't love it. And I don't want to get into a fist fight. But like, if we're going to have a real conversation around race, just remember you said it was okay. Because the bottom line is this country and its systems and isms is founded on stolen land. So let's start the conversation there. Everyone's screaming about Black and brown invasion. They weaponized it, they politicized it. And the bottom line is, at least to my schooling, that America was founded on immigrations. Give me your poor, give me your tired, and all of this. And now you've set up a system that says, you know what, this is ours. We stole it first. But no one wants to have that real conversation. So
yeah,
I'm going to stop there.
yeah. Okay.
Jason, any thoughts?
Oof. Yeah, I mean, the intersectionality of being a drug user kind of like, you know, inclusive of the racial dynamics that were just being discussed. But like as a social worker, looking at the issue of trying to work with drug users, and maybe, you know, there's some fear there, you know, maybe there's some like, oh, I'm coming into this thing and I'm afraid of, you know, like, I mean, here's the antidote for that, the medicine for that is humility, right? And being okay with not knowing, right? And it's not like we're trained to not know, right? But when you come into the situation and you lead with the fact that you are willing to learn and understand someone that you may even have some fear around, you know what I mean? Like to maybe even say it out loud, right? And put some words to that is super, super powerful. And I think relates back to the question earlier about how harm reduction it works in therapy, you know?
Yeah. Thank you, Jason. Joe, do you have other questions, or should we open it for folks to type their questions in the chat? What do you think?
I did, just also as an aside, I was listening to a podcast, and I'm forgetting, but it was a person who just wrote a book about sort of kind of the bigger picture around culture and race, and she was describing, and to Tavis's point, describing that there were public pools swimming pools, and that when the law required them to be integrated, that some towns closed the public pools because they, and so just kind of the level of fear that you're going, close these pools because you don't want to integrate, you don't want to interact with other people. Tavis, you had, when we spoke last week, you had mentioned a comment, or you wanted to maybe address it. And I also think it relates to just stigma as a whole. And kind of you talked about it as internalized, the internalized racism aspect. And then, but also I'm thinking too, that I think people who are drug users have that internalized stigma that they kind of carry around as well, that may prevent them from sort of engaging in treatment or advocating for themselves. But yeah, I wanted to give you that opportunity to talk about that.
Okay. Well, I also wanted to just circle back and say, not only did they close the swimming pools, they filled them with cement.
Right. Yeah.
So they could not be used.
Yeah.
That's right. That's right. Yeah, with the internalized racism piece, I just wanted to speak to how, I don't know if folks are familiar with the Willie Lynch letters and things of that nature. But in internalized racism, I had a situation where a supervisor, someone of color, just really used unprofessional language, attitudes, and all the wrong stuff. And I tolerated it 2 or 3 times, and then, benefit of the doubt, I'll give them a shot. Maybe this is their way of setting the supervisory environment. And then I said, the 5th time around, I was like, I'm drawing the line here. This is an impaired professional. And, I filed my paperwork around Workplace Violence Prevention Act. And I'm like, why have a policy that you're not following? And I was removed from them. But then I had to unpack it with some folks and unpack it with myself. And I really examined it, and I said, this is a person of color who doesn't identify as a person of color. And in that light, could it be that I'm just another Black guy who needs to be put in his place? Because that's the attitude and the body language that was being horrifically displayed. I can only call them as I see them and leave the floor open for your response. So that's not the only instance. I think our Black and brown folks are dealing with a host of internalized racism because of a system and a society that has so devalued us that we don't see value in one another. And in short, I like to say we've taken on the masters and the oppressors' mindset. That's why my social circle is relatively small, because most people don't unpack things that deeply or think that that conversation is rather corny. And I'm like, but you're being hoodwinked by all of these elements on a daily basis. Don't you want to be able to educate your children or maybe your grandchildren? When I was younger, I talked like this. I got kicked off the street corner. This guy's blowing a high, man, with these complete sentences. I wanted to tell kids about my book report on the great city of Pompeii. They was like, get out of here. And so drugs became the escape, but it took more than it could ever give. Very nice research, but I emerged with my brain fully intact, thank you, God. And then went on to school, went on to teach, And now I practice and I help others,
Yeah.
like put some good stuff in your brain. I mean, that's going to yield some dividends, some returns on your investment. And if not, I still wish you a good day. So yeah, the internalized racism thing, Joseph, is yet another tentacle, if you will, of what folks of color must contend with. You know, real quick, I remember trying to get custody of my 2 children, which I was ultimately successful. Took me 2.5 years. But initially, me and the mother were screaming, "We want a Black worker. We want a Black worker, someone that understands me and us and our children and our culture." Be careful what you pray for. You just may get it. We got one, and I ultimately separated from the children's mother because she wasn't participating in the service plan. I went on, and halfway through it, this woman wrote a note in my record that said I was hostile, aggressive, and threatening. And I said, could you be more specific? And the supervisor wants to have you strike that from the record or give the record specifics. She refused to come to the meeting. And I responded and said, I'm not hostile, aggressive, or threatening. What I said to you was I was only concerned that my children who are African American and Native American get everything that they are entitled to while in your temporary care. I got custody of them. They went up to Canada. They got free education. I now have 2 lawyers with no student debt.
Great.
Right.
So, Tavis, just to clarify, this worker who said that you were hostile and aggressive, they were African American?
Yes, she was.
Yeah. Okay.
Yeah. Yes, I think that's the piece around, representation is important, but representation that's steeped in perpetuating, because we've internalized that white supremacy culture and racism, right? And stigma and shame is not representation, right? Like, so we're not immune, I hear you saying, Tavis, as people of color, right? You and I, of swimming in this and embodying it and have it permeate our bones and our brains. And so there's work for us as people of color to be done to push back on that. Right. And that's the work that we as people of color have to do here. Right. White folks have to do their other work. We have to do the work of saying, you know what, like, this is not ours. It doesn't belong to us. This is not good for us. It can be a short-term sort of measure of protection for us, maybe a survival mechanism. But in the end, as you said, it's going to bite us in the butt. Yeah, it's not going to be good for us.
The other component, real quick, is that there's a power differential. She was the social worker in charge of the case and had total control of my children.
Yes.
I'm going to say jump and you're going to say how high. And so that also corrupted her.
Yeah.
And the level of awareness was obviously minimal, because you have to be aware of the power differentials, how your actions may be interpreted. And if you're not looking at these things, you're going to be a runaway train. And people are going to get hurt, and especially children who are already going through a traumatic situation. Absolutely. Not to mention a parent who's trying to parent, and to tie it into today's subject matter, I'm coming off of, a 10-year run on substance use. I had 6-7 years at the time. And all I want to do is take my rightful place as a parent in society. And you keep looking at me with this internalized racism, and I've got the scarlet letter of addiction on my back.
Yeah.
I'm curious.
We call them barriers.
Yeah. So I'm curious too, Tavis, one more question, then we can maybe open it up, is again related to Tavis's comments about sort of the internalized stigma of being a drug user and whether you had to deal with that and how did you deal with it? So.
I want to share the mic with Jason and then I'll respond.
Thank you, Tavis. Yeah, I'm just swimming in emotion over here. I don't know if I have to. There's a lot of stuff.
Yeah, man,
But I
it's
just see,
not for the
I
faint of heart.
see the tendrils of the racial thing in the stigma of the drug user thing too, right? Like in the part that you carry. And then the other thing that I heard being discussed was the unequal power dynamic of definitely in the, CPS, parental policing system, whatever you call it. But like, it shows up in clinical sessions as social workers, right? You're coming in as you're the practitioner, they're the client, right?
Mhm.
So having some awareness about that as you're entering and some, honesty about it, I think helps.
Right.
Engagement.
Yeah, thank you. Tavis, other thoughts about that? The internalized stigma of being a drug user and
Well, great question. I can remember first seeking full-time employment, early recovery. And I had a head full of, they're not gonna pick me. They're not gonna pick you. They're gonna find something in your record. Blah, 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 blah. All this self-doubt.
Yeah.
Yeah.
And because I'm a man of faith and a spiritualist, I said, I'm just gonna pray. I'm gonna go give them the best me I can and let the chips fall where they may, because I'm giving myself a migraine here and I haven't even started the interview.
Yeah.
And I went in there and I nailed it. Started my career with North Suffolk Mental Health Association in 1995.
Wow.
And I've been in this lovely, challenging, fascinating industry ever since, and nice trajectory. But I had to do my own work to what I call not moving into a new apartment because I need to change my location or this apartment stinks. No, I needed to move into a new mindset. And once I did that, I took it a step further and said, yes, you've got a head full of self-doubt. You've got this history. It's not politically correct. Once an addict, always an addict. And I'm putting my purse away. Don't put that guy's office next to mine. Da, 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 da. And I'm like, one, accentuate the positive. If I don't get the job, at least I know what's on the interview question. Then I got to a place where I used to say, I thought it was like mandatory that I announce I'm a recovering addict, right? And then, I just did some growing personally, and I said, you don't need to announce that as if it's some kind of cry for pity. I stopped using drugs, please. I just want to feed my family, right? And I stopped announcing that in the interview. And I learned in my process of recovery that I've always been enough. In fact, I've always been more than enough. But the disease comes with a lot of negative messages. And then there's the modeling in the home. I didn't get a whole bunch of positive modeling. So I was all messed up. But then I emerged and said, you know what? I've always been enough. Go get them. Go get them, man. The worst thing they can say is, no, we've gone with another candidate. And I've heard that before. Didn't ruin my day. I took the attitude, well, thank you for your time, but you just missed out on one hell of a mental health professional.
Yeah.
There you go. Thank you, Tavis. Thank you, Jason. We have a few minutes. I don't know if there's anybody in the audience that has a question that they would like to ask Jason and Tavis.
And I also want to say, if folks can please make sure, if your name is not showing in your Zoom little box, in your little box here, please go to the rename feature, click in the 3 dots, rename yourself and put your name in order for folks at NASW to be able to know who is here in case you don't get the code or there's an issue, because if your phone number shows, it's more complicated. So if you can please do that, that'd be great.
I wanted to say that, I'm in school again for a postmaster's graduate certificate on addiction assessments and new treatment approaches. And one of the things that is good about today is something we've been broaching, and that is the importance of culture in the therapeutic setting. It's been waived, it's been dismissed, it's been minimized, and there's just so much information to be mined, if you will, by looking at the client or patient cultural background. And remove your expert hat. I can't come in as a Black man and tell you about someone who grew up in Colombia. So it's okay to say, I don't know, perhaps you could share with me some of those things. And I think people embrace you as a provider who is not the knower of all things in all things.
Yep.
I think, and we've talked about this in the previous webinars, that at least for me, and I think you've talked, that I think taking a culturally humble approach, I think, and that has been a more used term than cultural competency, because cultural competency, I think, at least for me, is like you have to know a lot or know everything. And I think cultural humility comes from that place of not knowing and being open to being curious about other individuals. So
Definitely easier to achieve.
Yeah.
You don't have to just that, you can just be that right away. It's a
Right.
decision.
Yeah, absolutely. So we're getting just Jason and Tavis, so we're getting a lot of thank yous.
Thank yous.
Yeah.
Thank you.
Yes,
folks.
you're quite welcome.
Yeah, a lot of gratitude for sharing your generosity,
Yes.
sharing your expertise, your experience, your knowledge, yourselves in this space. I'm grateful for that. And it's thank you.
Yeah.
Well, all that I've been through, and I'm sure Jason as well, for me, it holds no value if I don't turn around and help somebody else, professional or personally, understand it better.
Yeah.
Not have to go through some of the things I went through, and like, they're not doing the greatest job of teaching these things in our lovely, overpriced institutions of higher ed.
Yeah, absolutely.
Yeah.
Yeah.
Yes.
When I taught at the undergrad level, I said, welcome, here's what we're doing, let's go through the syllabus, and I am not going to give you stuff that you're expecting. I'm going to give you some stuff that they will not share with you in most institutions, but they are real world applicable.
I would add too that, like, some of the best practitioners that I've ever experienced have done some time volunteering at harm reduction agencies, like therapists and medical people that have come through the milieus that I was part of, and like just picked up on some of that grassroots knowledge that harm reduction has. I mean, it was originally illegal, right? And so it definitely has that revolutionary grassroots like practices that can be picked up if you're around it for a minute.
Yeah, And
Right.
ingenuity, right, Jason? Ingenuity, because
Yeah.
in the beginning, we didn't have like financial resources. We have human resources, right? We have people that care about
Right.
people, and had they said, you know what, it's illegal, but this has to be done because what's legal many times is not right, and
Right.
people are dying, and our
Still
community
true.
needs to care for each other, right? And I
Yeah.
feel like that ingenuity of like sometimes we're so locked in and we need all these big things to do something. No. To change
Yeah.
hearts and minds, you start by changing your own heart and mind, but you have to have
That's
the
right.
willingness to do it. So thank you for bringing it to the history. Thank you.
And maybe to end, we still have a lot more work to do and to go, but the fact that the president's sort of statement about harm reduction in their approach to treatment of addiction, the fact that it's actually mentioned, the fact that there's actually money that's being sort of allocated, I
Yeah.
think is, certainly, again, I've been in the field a long time. 20 years ago, I didn't think it would be
Unthinkable.
possible.
Yeah.
Unfortunately, it needed thousands of people to die, unfortunately, but I am glad that this is occurring. So on that note, I will end there. So thank you.
Yeah. So next time we meet, we're going to take a look at crack cocaine versus powdered cocaine in
Yes.
the criminal justice system.
Yeah, there
We
you go.
will.
Yeah,
Yes.
yeah, yeah,
Yes.
Interesting
Yes, for
disparities, yeah.
sure.
Right.
We
right,
will.
Yeah.
Yeah.
We do.
Um,
At least we do in our trainings, National Harm Reduction Coalition.
no.
We do in our trainings.
Yes.
No
So-
one said you can't have fun in our educational process,
Right.
Mhm.
because this is serious work. And,
Yes.
and we need to be able to breathe in and out,
And reclaim joy.
So
Yeah.
yeah. So I think Chris Belli or Barbara, you're going to have the code for the CEUs. So we're going to pass it on to you.